Welcome to day 2 of the 2020 C-TAC Virtual Summit on Advanced Illness Care. My name is Arif Kamal. I'm a physician, researcher, and associate professor of medicine at Duke University School of Medicine, and a medical oncologist and palliative medicine specialist. I'm honored to share something about myself and my work a little bit later in today's plenary session. As you've clearly noted throughout yesterday's abundant offerings by such notables as Wes Moore and Ira Byock, the conditions of health inequity that have come to prominent attention in the light of the COVID-19 pandemic are startling. The African American, Hispanic, and Latino communities have been disproportionately impacted, as have the sovereign nations of the Native Americans. We want to begin our plenary session today with the opportunity to hear the voices of those speaking for communities and tribes so severely impacted. We begin with historical context, then listen to the voices for change.
My name is Julie Smithleck. I'm the Executive Director of the Center for Community Health Alignment at the Arnold School of Public Health, the University of South Carolina. I'm here to talk to you today a little bit about the historical context around disparities and equity. So as you know, a disparity is a difference in outcomes that we see between different groups. So differences between racial and ethnic groups, differences between folks with different ability statuses, gender identities, etc. And disparities are most often seen in groups that have experienced greater obstacles. So then, just to remind us again, what is equity? Equity is when everybody, no matter what their status, no matter what type of group they're in, no matter what box they're categorized in, has the same opportunity to be healthy and to achieve the well-being that they want for themselves and their families. So what are the roots of some of these health inequities? Well, you got to look at the policy realm. It's not just about what we're doing today. It's about the policies that are infused from throughout our history. So look at policies like Jim Crow laws, which again were less than 100 years ago, when different populations, when the Black population didn't even have the right to be in the same places, to work in the same type of jobs, to go to the same type of schools as their white peers were allowed to. Look at redlining policies and home ownership and the ability to live in certain areas, to have businesses in certain areas, and the effects of those policies. You also have to look at policies around the court system and policing that result in more people of color, and especially Black men, ending up incarcerated than any other group. And the effects, the large scale effects that those type of policies have on their families, on their communities, on their ability to work, on their abilities to vote, and the trickle-down effect of those policies on those entire communities. Then you look at policies like anti-immigration laws or English-only laws that affect our immigrant populations. And even those immigrant populations that may not be affected by those particular laws because of their citizenship status, they are affected by the anti-immigrant sentiment that is pervasive in our country and has been pervasive and is certainly quite strong right now. For our Native American population, we can't forget the Indian Removal Act and the effects that it had that led to the Trail of Tears and our Native American brothers and sisters being forced to live on almost uninhabitable lands, on reservations that were foreign to them, that they had to adjust to because they had no other choice. And many of what this decision, this policy, and the conditions that they found when they were forced to live on these lands have basically led to those communities being impoverished since that was enacted.
Watsi Hopa. My name is Brian Vayo, and I'm the governor of the Pueblo of Acoma here in New Mexico. This has been a great strain on all of the world. And I think for us, it's been very important to acknowledge, first of all, our cultural understandings of these types of experiences, many of which have been prophesized by our ancestors.
My name is Emily Houses. I'm Chiricahua, Fort Silapachi. I'm a nurse. I have a PhD in nursing, so I'm a doctor nurse. I think a lot of people think about COVID-19 as being a past tense or something that we can sort of shelter ourselves from, but in Indian country, it's not past tense, it's happening for everybody, everywhere. We still have tribes that are on total lockdown. And they're going to remain on lockdown until they're sure that they're safe. We've already lost a lot of people, and elders are most sensitive to this. So we want to protect our Native American communities. We want to protect our elders as much as possible. So our immediate short-term needs are really simply saving lives, protecting our people.
My name is Gail Denette-Chacon. I am a family medicine physician. Originally, I'm from Chinle Navajo Nation. I grew up there, and currently I am a professor in the Department of Family and Community Medicine at the University of New Mexico School of Medicine. My main role is that I am executive director of the Native American Budget and Policy Institute. Although I have spent my life seeing patients as a medical doctor, putting my finger on the pulse of individuals and understanding their health status, now I see my role as putting my finger on the pulse of the American Indian population, especially Navajo Nation, to understand that health status and where we are in the big picture of policy, research, health, chronic disease, economic development, environmental justice, and institutional racism as it impacts the health of our communities, children, and families. The impact of COVID-19 and this worldwide pandemic has certainly, as everyone knows, made the greatest impact on our Native communities, as well as our African American brothers and sisters, and our Hispanic and Latino communities as well. We, as American Indians, have seen this impact not just today. The ground on which we stand has been shaped by 500 years of genocide, systemic racism, and economic injustice. So many of the exacerbating problems that we're seeing today, we have been all under the radar, and we have lived with these for hundreds of years.
My name is Dr. Gus Reyes, and I am the director of the Christian Life Commission for the Texas Baptist Convention. It represents and ministers to about 5,300 churches in Texas. And then I also serve on the executive committee of the National Hispanic Christian Leadership Conference that speaks to gatekeepers representing about 40,000 Hispanic evangelical churches in the United States and many, many more globally. It's kind of traditional within our culture not to go to the doctor. You know, we have a practice of, we just don't go to the doctor. And so what happens is you don't go to the doctor and you're doing okay, you know, you're healthy as long as you don't go to the doctor. But when you can't stand the pain anymore, when you just can't help yourself, you go to the doctor, all of a sudden these examinations occur, MRIs, et cetera, and all of a sudden they find things that are probably terminal. It's probably been it's too late, you know, to get the kind of maintenance and preventative medicine that we're so well known for as a country. And so it's too late. Well, one of the concerns of that demographic, of that group of folks, is that, you know, many do not have Social Security numbers. Many do not know how to engage the health system. It's not just a matter of having insurance or being able to engage it, but if you don't know the process and how to engage it, that's another piece. And so, so I would say that in general, the Hispanic community really is challenged with a lack of understanding of the healthcare system. And many times people feel like if you don't have your papers, you're not documented, that maybe those privileges are not for you. And again, add on that layer of, we just don't go to the doctor, but they come here. And so the idea, they're going to charge me to go to the doctor. They're going to charge me to go to the hospital. I don't keep that kind of money. I mean, you know, folks are living from hand to foot, you know, from Sunday to Sunday, from paycheck to paycheck. And now you want me to pay for to go see the doctor. Wow. So when we talk about needs, healthcare is a big need. It's a tremendous opportunity.
We have this crisis, the gaps in care that we already had became glaring. So when we look at long-term needs, how are we going to fill in these gaps that are gaps that they're not even gaps, they're chasms. This is the Grand Canyon of healthcare gaps in our country. We have facilities that haven't been updated in several generations. We have hospitals that are functioning at 20% of capacity because they just can't function at anything else. We have GAO, the Government Accountability Office. They have done report after report after report for years saying that IHS is a crisis. So there's no excuse for what happened in Indian country. Now it's a matter of actually prioritizing Indian lives, Native American lives, and paying attention to who we are and paying attention to our problems and actually directing resources so that we don't have this happen again.
Funding at the federal level, adequate funding for healthcare and for education. It is written in treaties. It is there to be done, to be had. What more do we have to say that we have facilities, we have clinics and hospitals, not enough, but that are basically underfunded, that are in very poor condition. We don't have enough healthcare workers. We would love healthcare workers that are Native, who look like the patient population they are serving, and come from those communities. And we don't have any of that. We have very few. So having a good workforce, especially a healthcare workforce.
We realized early on that our broadband access is limited, and other infrastructure needs are also at the forefront. And so we need to ensure that the tribe is doing all that we can with the resources that we have to ensure that we have the capacity to address the needs of our community moving forward. Just recently, we were informed by the Indian Health Services that our ACL hospital service unit is potentially going to undergo a significant change as a result of one of the tribes pulling their shares, basically half the hospital's budget. If there was a significant change as has been proposed, we will be left in a very dire situation. Not only Acoma, but the neighboring communities as well, including the tribe who is pooling their shares, because there would not be access to an emergency room.
We have treaties with the federal government as American Indians, and those treaties have provided healthcare, education, infrastructure, in exchange for the lands, the very lands that the United States has been profited from and has built many of the cities and developments, and yet American Indians who suffered by giving those lands or ceding those lands over to the federal government have suffered greatly with health disparities, high unemployment. It's not unheard of to see unemployment at 40 and 50% rates in our communities.
This will take some very involved advocacy and government-to-government consultations and meetings to ensure that the needs of the Native American people are considered and that the resources that will be needed in our respective communities is made available.